Okay, so welcome everyone to this clinical webinar this evening. So we have our guest speaker, who's Dr. Lynette Sadleir, who's a professor at the University of Otago in New Zealand. We've been doing some work between SNOMED International and the International League Against Epilepsy. So this seemed quite a good time to share some of the work that the ILAE are doing themselves, and also some of the work that they're doing with us. So the way this session works, for those of you who haven't been on webinars before, we're using Zoom webinar, which means that you as the audience can't talk. But we welcome you to write questions either in the Q&A box at the bottom of your window or in the chat box. I don't mind which, either will do. We'll run the session for an hour. The presentation lasts for about 45 minutes, depending on how soon I shut up. And then we'll have some time for questions at the end of the session. So I'm going to hand over to Lynette and put myself on mute. So Lynette, over to you.
Thank you, Ian, and thank you to everybody for coming and listening to this presentation about SNOMED CT and epilepsy. I thought I'd just tell you a little bit about myself and how I ended up here giving you this talk. As Ian said, I'm a pediatric neurologist. I'm an epileptologist. With my clinical hat, I see children in Wellington, New Zealand who have seizures and epilepsy, and I read pediatric EEGs. And my academic hat, I run an epilepsy research project, predominantly looking at epilepsy genetics. And as part of my clinical hat, I was involved in the Ministry of Health of New Zealand Epilepsy Improvement Project, and where we were aiming to try to improve quality of care in New Zealand for individuals with epilepsy. And the group realized we really needed some more data to help us figure out where the gaps were and how we could allocate resources better. New Zealand doesn't gather outpatient data, which is where predominantly most of the individuals with epilepsy are seen. But the Ministry of Health are aiming to do that, and we were told that they were going to start collecting outpatient data and they were going to start using SNOMED. So I had never heard of SNOMED before, and I, as part of the group, went to have a look at SNOMED and see what that actually meant and what the terminology in there was around epilepsy and seizures. And I had a look and I thought, oh my, this isn't really up to date. And so I went back to them and I said, oh, I don't think we can use this. I went to our SNOMED people here in New Zealand. I said, oh, could we change this? Because this isn't really up to date. And they said, oh, well, no, this is a big international thing. So then I spoke to Helen Cross, who's now the president of the International League Against Epilepsy, who is a UK pediatric neurologist, and she uses SNOMED in her day-to-day practice, and she realized that it wasn't ideal. And at that stage, a SNOMED task force was put together from clinicians in the ILAE who had been involved in classification and terminology, and we developed this partnership with SNOMED to move forward. So that's how I'm here. And so I want to start off, first of all, with a case. So this is sort of a slightly made up case, although the videos are all the same girl, and she has kindly given me permission to show them all to you. But we're going to call her Julie, and she is a 2-year-old girl who's had normal development, normal exam, no family history, and she presents with multiple daily events that look like this. Now, hopefully I'm not going to deafen you because it was quite loud. Oh, hold on. I'll make it a little bit less.
She's getting one right now. Yeah.
So those events continued on a relatively daily frequent basis. And then at 8 years of age, she started having events which were much longer, and she would go for 20 to 30 minutes. And this is what these events look like.
Do you remember getting some texts this morning? Can you hear me now? Do you remember getting some text this morning?
And this would just go on for 30 minutes. And around the same age, she also presented with these events. So now that you've got your head into what we're talking about, what I'm going to go through over the next 40 minutes or so is I'm going to start by talking a little bit about epilepsy and give you some background so that make sure we're all on the same page. Then I'm going to let you know about the International League Against Epilepsy and how it's been involved in and its history in terms of classification and terminology, what the processes have been and progress that's been made. Specifically, I'm going to introduce you to the newest ILAE position papers, which is outlining the most up-to-date concepts and terminology. And then I'm going to give you an example using absence seizures of why things change and evolve over time and what leads to that. And then finally, I'm going to talk a little bit about what we're hoping to do in the SNOMED ILAE collaboration. So those videos I've just shown you are all epileptic seizures, and an epileptic seizure is defined as a transient occurrence of signs and or symptoms that are due to abnormal, excessive, or synchronous neuronal activity in the brain. And people often think about epilepsy as a single disorder, but it's actually, and it's defined based on the definition, or the easiest definition is 2 or more unprovoked epileptic seizures. But epilepsy is actually a group of disorders. And so just like you can see that this is a picture of fruit, but it's pretty easy to classify that fruit into individual types of fruit. And so with epilepsy, the most important thing is to try to make a diagnosis of an epilepsy syndrome. So epilepsy is actually a cluster, a group of different epilepsy syndromes, and an epilepsy syndrome is defined as a characteristic cluster of clinical and EEG features, which are often supported by specific etiological findings, but not always. And the syndromes are defined based on the age of onset that the individual presents with seizures, the specific types of seizures they present with, and subsequent types of seizures they develop, their developmental profile and trajectory, what we find in their neurological examination, the comorbidities they have, such as intellectual disability or movement disorders, and then what is found in their MRI and more specifically their EEG. So why does it matter? So why are the syndromes so important? They guide us in terms of what investigations might need to be done. It allows us to give prognosis in terms of seizures, what's going to happen long term, and comorbidities, what might develop and when. It provides etiological information, so helps us to specifically look for particular etiology. But really importantly, it guides management. And also it enables effective research. So, and that research is important for developing better management, better precision therapy, and for us to understand where gaps in care, etc. So the World Health Organization a few years ago declared that epilepsy is a public health imperative. They said that epilepsy is the most common serious brain disorder worldwide, with no age, racial, social class, national, nor geographic boundaries. And it's estimated that between 40 and 50 million people suffer from epilepsy in the world, of which about 85% of those are in developing countries. So now, who are the ILAE? I always thought when I first heard of the ILAE, it's a sort of an odd name. It sounds like a bunch of superheroes, which indeed some of them are. But this is an organization that has been around for a long time. It was established in 1909. Perhaps that's why it's the International League Against Epilepsy. And it's the world's preeminent association of healthcare professionals and scientists who are working towards a world where no person's life is limited by epilepsy. And this group is full of healthcare professionals from all different areas. So this is allied health, psychiatrists, pathologists, neurologists, everybody that has anything to do or cares about epilepsy. And together, the ILAE's goals are to be the international resource for standards and best practice, to enhance knowledge and skills in epilepsy care, and to ultimately promote research and innovation for epilepsy. And the way the ILAE works is it is a group of chapters, and there are over 140 countries that have an ILAE chapter, and each chapter has members of allied health and individuals that are interested in epilepsy care. So when you look at that with SNOMED, you can see that we definitely overlap. So the International League Against Epilepsy has chapters in all the SNOMED countries, except for Iceland and Brunei, but I'm sure that we're trying to get them into to have chapters as well. And the goal of our two organizations is to enhance the content related to seizures and epilepsy in SNOMED CT, so we can ensure that clinicians have the latest evidence-based content available to them for point of care recording, and that ultimately that can be used to help identify gaps in care, allocate resources, and to be useful in terms of research. So the ILAE terminology and classification of the epilepsies has several underlying philosophies. So the purpose of this is for clinical diagnosis first, and research and resource allocation is also really important, but this is about clinical diagnosis. And it's also important that this isn't just for epileptologists who may be sitting in their ivory towers. This is for everybody that has anything to do with people who have epilepsy, including people with epilepsy themselves. And so it's important that this language is transparent, that words are used that mean what they say, and that they're easy to understand, and that they translate well into different languages, and that they're appropriately can be appropriately used in all countries. And so all of these philosophies have been really important in terms of the ILAE in its proposals for classification and terminology. So there's been ongoing efforts to refine the classification of the epilepsies since the inception of the ILAE in 1909, and that gained particular momentum in the early 1960s when new concepts of classifications were proposed, and I've listed them here on this slide. And there was intense debate and acquisition of new knowledge in the next couple of decades after the first classification in 1970, and that led to the landmark 1985 ILAE classification of epilepsies and epilepsy syndromes, which was soon followed by a revised version ratified by the General Assembly, ILAE General Assembly in 1989. And it's this 1989 classification has been incredibly highly influential worldwide and has a major impact on epilepsy care and research. And this is what is predominantly embedded into SNOMED at the moment. And although the concepts outlined in the 1989 ILAE classification are still valid to the day, many of them, it became increasingly clear that revisions were needed to account for subsequent scientific discoveries that over the last few decades have fundamentally changed our understanding of the epilepsies, as well as our approach to the diagnosis and management of individuals with epilepsy. The other thing the ILAE realized is that they needed to have a robust system to implement and to decide what needed to be changed, how it would be changed, what could be built upon, and then how this would be implemented. So they put into place in 2013 a process for the ILAE to develop position papers. And that process it starts off with the executive of the ILAE deciding that it's time that something needs to be revised or updated or modified, and they put together a group of experts in that area and form a commission. The commission goes to the literature, looks at the previous work, builds on that, modifies, makes recommendations as they feel appropriate. That then goes back to the executive, who makes some suggestions. And then when the commission and the executive are happy, then it goes out to consultation. And consultation is a fairly robust process where these papers are put onto the ILAE website, and everybody that all of the members and all of each of the chapters are sent emails to look at them and to provide feedback, as are other organizations that are that use these terminologies. Then once the end of that consultation process, then there is the executive appoints an independent task force, which has some of the commission members, but is also individuals that haven't been on the original commission. They look at the feedback that's come from the worldwide consultation, and then they modify the document. It goes back to the executive, and then ultimately, and this is a long process, it comes out in Epilepsia, which is the ILAE's international journal, as a position paper. So since 2013 in this process, there have been some seminal position papers that have been put out by the International League Against Epilepsy. The first one in 2014, which was a revised practical and clinical definition of epilepsy. And then in 2017, there was an operational classification for seizure types and for classification of the epilepsies. Last year, there was a position paper with modifications for seizure types and epilepsy, specifically in the neonate, because they are quite a unique bunch of little individuals. And then next year, the ILAE will be putting out 5 position papers on the classification and definitions of epilepsy syndromes. And this has been a long process of two terms of task forces. The consultation went out last year, and it's about to be published. So what does it look like? So this is the diagnostic schema of the 2017 International League Against Epilepsy, Seizure, and Epilepsy classification. And I'm going to take you through, not everything, but bits of this so that you understand a little bit about some of the changes. So first of all, seizure types. So seizure types are classified based on their where they start, so their onset. So there are focal onset seizures, generalized onset seizures, and there's a category of seizures where we don't know what the onset is. From a SNOMED perspective, these are the findings. And how these seizure types are defined are based on several things. They're based on seizure semiology, so what actually happens in the seizure, what you can see, what the patient feels. And what's important is the level of awareness, what motor features, as well as what sensory features that the individual can feel. And this, as well as the EEG, is put together and defines the seizure types and whether they're focal onset, generalized onset, or unknown onset. So the 2017, first of all, let's just talk about onset. So generalized seizures in the 2017, one of the changes was that they are felt to originate at some point within and rapidly engage bilaterally distributed networks. So it's all about where they start, and it's all about the networks. And so here is a cartoon showing you a bilaterally distributed network. This is the corticothalamic network, and this is one of the networks that generalized seizures start in. And this is another MRI showing you some functional MRI data, which highlights the areas in the brain that are working, I guess, or not working, when these networks are being engaged in these generalized seizures. And then we have focal onset seizures, which originate within networks which are limited to one hemisphere. So you get a lesion or which activates a unilateral hemispheric network, and that might stay localized to that network, or it might move over to another localized network on the other side of the brain, or it might spread to involve a bilateral hemispheric network, such as the corticothalamic network. But it's all about where it starts, so it's focal and onset. So the 2017 classification, the focal onset, generalized onset, and unknown onset seizures are then described or classified in more detail. It's really important, particularly with the focal onsets, about the level of awareness, and then whether there's motor features or non-motor features. And then if it spreads to to involve bilateral tonic or clonic jerking of the body. Now, previous to this 2017 classification, if a seizure which started in one part of the brain spread to involve the whole brain, it was called a secondarily generalized tonic-clonic seizure, and that was confusing. We now are using the term generalized to only apply when the seizure starts and generalized. So therefore, there needed to be a new terminology which was easier to understand when the seizure spread. So a focal seizure which spreads to involve the whole body is now classified as a focal to bilateral tonic-clonic seizure. And you can be more granular in your classification as there's other terms within each of these categories. So in 2017, specifically, the position paper recommended that the terms in the 1989 classification, such as complex partial, simple partial, partial psychic, dyscognitive, and secondarily generalized tonic-clonic, that they were difficult to understand. They weren't, and people were confused by them, and so they're not helpful, and that they should no longer be used. And just to note that terms like petit mal and grand mal were actually felt to be outdated back in the 1970 classification. So those are the findings of the seizure types. And the seizure, it's really important to make sure that diagnosis of the seizure type is as accurate as possible. You use those seizure types to help you identify what type of epilepsy an individual has. And so the epilepsy types a person can have can fall into broad categories of focal epilepsy, generalized epilepsy, or combined generalized and focal epilepsy, which is a new type of epilepsy in the 2017 classification. And then ultimately combine the history and other features allow you to define an epilepsy syndrome, or that's the aim. Sometimes you can't. Everybody doesn't fit into an epilepsy syndrome, and sometimes the best you can do is say that they've got a focal epilepsy. But at any stage, so the further down you go in this diagnostic schema, the better information you're going to have in terms of prognosis, etiology, management. And so in SNOMED, these are the disorders, epilepsy types and epilepsy syndromes. From a SNOMED perspective, these should be considered the disorders, I should say. In terms of the epilepsy syndrome, so this is a very busy slide with a lot of letters on it. And basically, each of these colored blobs represent a ILAE recognized epilepsy syndrome. And we're not going to go through all of them, but just to give you an idea of how they're sort of classified. So this is age of onset across here. Each of these blobs represents at what age the individual presents with this particular seizure type. The blue colored syndromes are focal epilepsy syndromes. The green colored syndromes are generalized epilepsy syndromes. The yellow are combined, and the red are the developmental and epileptic encephalopathies, which is another category within the epilepsy diagnostic schema. And you can see that they present at specific times in life. So, but the ILAE classification, the task force, the commissions and the ILAE felt that it's not, that there's more to epilepsy than just the syndromes, and that it's important to think about the etiology. So they defined 6 different groups: structural, genetic, infectious, and metabolic and immune etiologies that can cause epilepsy, and also recognize that there are a lot of comorbidities associated with epilepsy. So that is the diagnostic, sort of a pictorial representation of the 2017 diagnostic, classification. And so now we're going to put this back onto Julie. So remember Julie, she presented when she was 2 years with multiple daily events, normal development, normal exam, and no family history, and that this was the first seizure. Hopefully it's not going to be so loud again. Oh, I'm so sorry about that. Here, we'll go back here. So the seizure started here. She was crying, and then you hear, just turn the volume down, and then you can hear her having vocal automatisms. She's got manual automatisms as she's playing with the teddy, and she's unresponsive. And it was a pretty abrupt onset, and it's very abrupt offset where she starts crying again. So this is the EEG that you find with that event, that epileptic seizure, and this EEG shows generalized spike and wave, and that event was a what would be classified in the 2017 by the 2017 position paper as a typical absence seizure. So at 8, when she presents with these events, so now you can see, so these are prolonged 20 to 30 minute events where she's got rhythmic 3 hertz eyelid
Do you remember getting
jerking.
some texts this morning?
And she's unresponsive to her dad, but she's kind of in and out. So at one stage, she sort of says, She's got some blinking, her eyes deviating a little bit. And this goes on for 30 minutes. And the EEG associated with that is, again, 3 hertz generalized spike and wave, but it's not as organized. It sort of comes and goes. And these events are episodes of absence status. And then finally, the last event that she has, where you can see this bilateral, it's lagging here, don't know why. It's lagging for me, so that's not good, but hopefully you can remember what it showed. So she had, why is it doing that? Let's just, she's got bilateral arm and leg clonic jerking. And the EEG associated with, well, her EEG shows generalized spike and wave, and that is a generalized tonic-clonic seizure. So for Julie, her seizure types are all generalized onset, and she has typical absence status and generalized tonic-clonic seizures. And this is just a summary reminding you that she had normal development and exam, no family history. Her EEG shows generalized spike and wave, and her MRI was normal. So we know her seizure types. She has a generalized type of epilepsy, and she fits nicely into a specific epilepsy syndrome, which is known as early onset absence epilepsy. And we know in terms of, so the other thing is, just to let you know, she has got some socialization difficulties, which is one of her comorbidities. And in terms of her etiology, we know that this from family studies and twin studies that this type of epilepsy is genetic. And indeed, 10% of individuals with this type of epilepsy have been found to have, as she has, a pathogenic mutation in a gene called SLC2A1, which is a gene which codes for a protein which takes glucose across the blood-brain barrier. So it's important in terms of providing fuel in the brain. And if you have a variant in that, you end up with a GLUT1 deficiency. So this is her syndrome, early onset absence epilepsy is one of the GLUT1 deficiencies syndromes. And that's really important because there's precision therapy for this, and that is the ketogenic diet. So the ketogenic diet is a very stringent diet, which has got high fat, high protein, and it tricks the body into thinking it's starving. It has high levels of ketones, and that's great because ketones can be used as fuel, and they cross the blood-brain barrier. And so individuals with variants in SLC2A1 can go onto the ketogenic diet, and their epilepsy improves, as does any cognitive issues if they have that as well. So she has got not just a genetic epilepsy, it's also metabolic. So Julie has a early onset absence epilepsy. The etiology is genetic metabolic. So that's how we use the classification. And now I'm going to take you through a little bit of, and I'm going to use absence seizures, and I'm going to use there's lots of different things I could have taken you through, but absence is what I did my doctoral thesis on. So it's what I know the most about and was involved in. So I'm going to talk to you a little bit about absence seizures and the rationale for why things have changed in terms of the terminology. What is the science and the evidence that's led to the changes? And also a little bit about the history of how we got to where we are in the 2017 classification. So remember, this is the 2017 classification, generalized onset, motor, non-motor. So the non-motor seizures are the absence seizures. And the 2017 classification divides up the absence seizures into 4 different types: typical absence, atypical absence, myoclonic absence, and epilepsy absence with eyelid myoclonia. So how did we get to that? Where did we start? So originally, although tonic-clonic seizures were sort of, written about and known about from back 3,000 years ago, absence seizures are a little bit more recent. I mean, they've been around, but sort of people describing them and classifying them. And originally, the only way they could do that was by taking histories from people who are watching them. Now, the thing about absence seizures is they tend to happen quite frequently. So you get, people can watch a lot of them. And indeed, sometimes you can get them in the clinic. They can sometimes be induced by hyperventilation. So you can watch them in real life. And so early on, amazing clinicians who watched a lot of events and took great histories, first described these events in 1705. And in 1815, the term petit mal was introduced. And not shortly after that, also the term absence, which was felt to represent, or supposed to, due to the fact that there was an absence de spirit, so people kind of left their body. But what the major advance, or technical and scientific advance, was in 1933 when the EEG came along. And so some of these staring spells or absences petit that were being identified back before that actually were not what we consider absence seizures today. They were focal impaired awareness seizures. And it was quite clear that the staring spells that were associated with 3 Hertz spike and wave were indeed different. And so this was a major advance in terms of our understanding about absence seizures. So prior to 1963, after the EEG became available, people talked about petit mal and petit mal variants in terms of classification of absences. And it was predominantly just based on the EEG features. So somebody was staring, and if the EEG showed 3 Hertz or faster, it was a petit mal. And if it was slow, 2 Hertz, it was a petit mal variant. And they recognized at that time that people who had absences that were petit mal variant had different types of epilepsy and different types of outcomes. So they felt it was important to differentiate those 2 types of events. Around in the early 1960s, the terms petit mal and petit mal variant were going out of fashion. People started talking about typical and atypical absences. And then what happened in the next advance was in the late 60s, early 70s, it became possible to link up telemetry, video telemetry with the EEG. And so what that allowed was people to get, so this is very much a research tool, and they would get individuals who have absence seizures in, and they would look at them in great detail to see what was actually happening in these absences associated with these EEGs. And it was these studies studies looking at the semiology of absence seizures, and when I say semiology, that just means what's happening within the seizure, that were instrumental in the next classification, which came out in 1970, where they got rid of petit mal and variant, and they also didn't use typical and atypical, and they started talking about, or they used the term simple absences, which were absences where you just stared and did nothing else, and then complex absences, and those were differentiated into 5 different types of complex absences, ones with mild clonic components, ones with increased tone, some with automatisms, some with decreased tone, and then some with autonomic phenomena such as incontinence. And so it was because they could see these absences that they decided to divvy them up based on what they looked like from a semiological perspective. And the 1981 classification realized that actually they'd thrown the bit of the baby out with the bathwater. That atypical absence defining using the EEG was actually very useful and helped define specific groups of epilepsies. And so they put that back in, but they kept the absence seizures divided up predominantly by semiological features. So the next big step was when video EEG became available clinically. And so it's first of all started in the tertiary centers, but now, you know, any child or any individual that comes into hospital, they don't just get an EEG, they have a video being recorded at exactly the same time. And because absence seizures are frequent and because they can often be induced by photic stimulation or hyperventilation, that means you can capture them, and you can capture lots of them, and you can capture them at the onset of disease in populations that represent, in groups of people that represent the whole population. Whereas previously the video telemetry, it was just using very small research groups. And so there's been a number of large studies looking at new onset individuals with absence seizures, and that was indeed what my doctoral thesis was also about, that have led to the changes in the 2017 classification. So the 2017 classification, they realized, and so the big thing about back here in this is that it, rather than worrying so much about what the semiological features were, which had been well defined by these original studies, what we're more interested in is, well, did it matter? What does it mean having these semiological features? Does it impact on treatment? Does it matter in terms of prognosis? And now that we could get clinical patients that were like everybody, because everybody was getting a video EEGs, we could look at big groups of different types of syndromes and figure out, was this semiological differences important? And so it turned out that no, most of them weren't. And so that's why the 2017 classification has changed, so that all of these pink types of seizures have now been put together in terms of the typical absence seizures. Atypical absence seizures are clearly an important type of seizure. They're still there. And then they pulled out two particular types of absence seizures, myoclonic absence and absence of guided myoclonia, which previously would have been a part of this not all of, part of this group, because they recognize that there are particular epilepsy syndromes where these seizure types are the predominant seizure type, and they are really helpful in terms of you need to have those seizure types to be they're part of these syndromes. And so having these as well-defined and classifying these types of epilepsies is important in terms of prognosis and management and subsequent research. So they added those in. So I'm going to, just to give you sort of more, go a little bit more specifically into, why, what was the research and why did they decide these semiological features weren't important? And part of the reason why I'm bringing this up is this is one of the areas we're working with SNOMED at the moment, is that we're going to aiming to get to inactivate terms in SNOMED which are not helpful, and these are no longer, we realize, are no longer helpful, but they are still in SNOMED. And one of the ones that's not helpful is automatism. So I'm going to take you through some of the research that I actually did with my colleagues that supports why that is. So remember that to get to seizure types, you're looking at seizure semiology as well as the EEG. And so the semiology is what actually happens in the seizure. And so automatisms is a type of semiology. And an automatism means a more or less coordinated repetitive motor activity, usually occurring when cognition is paired and for which the subject is amnesic afterwards. So basically, it's just something that somebody does in a seizure when they've got an altered awareness. And it can be oral, it can be lip smacking, it can be picking at their clothes, or it can be vocal, like you saw in that first seizure of Julie's with the bah, 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 bah that she did, and also the hand movements of her teddy bear. So that's what automatisms are. But it does not help you differentiate. Just because you see automatisms doesn't tell you whether the seizure is focal or generalized. But what about in absence seizures? Well, they're common. And so about 63% of absence seizures will have some sort of an automatism. It's not necessarily the same automatisms. And up to 100% of children will have automatisms in at least one seizure at some stage. And about 67% of children will have automatisms in every seizure, but the automatisms won't necessarily be the same. So I'm going to talk to you a little bit about how we did this and what we did. So, and this particular study looking at automatisms and other features of absences was published in Archives of Neurology in 2019. So this was a study that I did as part of my epilepsy fellowship, and it was on new onset absence seizures in children, so children between the age of 1 and 16. And we had 70 children, and they had a variety of different epilepsy syndromes in which absence seizures are a feature. So there was many syndromes, but the major ones, which are the most common, were childhood absence epilepsy, and then juvenile absence epilepsy and juvenile myoclonic epilepsy. And each of these syndromes are treated differently and have different prognosis. And we looked at 509 seizures at the clinical and the EEG features in painstaking detail, as you do in a PhD. And these seizures were captured in different states in the EEG. So when they're awake, drowsy, and sleep. We looked at one EEG, the first EEG for each child. They were not on medications at this stage. And the other thing we looked at was whether or not the seizures changed based on whether they were induced by photic stimulation or by hyperventilation. And so if we look specifically just at these children, so this is a graph showing all of the kids. So this is, each number is an individual child, and the light blue are seizures that they had without automatisms, and the dark blue with automatisms. And you can see over here, these are the number of seizures that we captured in the EEG. So what you can see is there's a variety of number of seizures that were captured in the EEG for each of the children, ranging from 17 and a 30-minute EEG. These are just 30-minute clinical EEGs down to 1. And that most children had automatisms, but a lot of children had seizures without automatisms. And so we did some part of the team was Bendix Carstensen, who was an excellent statistician, because the statistics of this was a little bit over my head. It involved a lot of complex analysis to look for confounding factors. And what we did was we looked at what was important. Why do you get automatisms? And what was it about the kid that was making, or the environment that was having something to do with this? And was it an important feature of their syndrome? And so we looked at the odds ratio of having an automatism. So this is an odds ratio of 1 in each seizure. And so first of all, let's look at the top here. So this is looking at the syndromes. So CAE is childhood absence, JME, juvenile myoclonic absence, and juvenile absence. JAE is juvenile absence epilepsy. And you can see that the odds ratio, it all overlaps. So it doesn't, having automatisms makes no difference. It doesn't impact at all in terms of what kind of epilepsy syndrome you have. So it doesn't, whether you have seizures with automatisms or not, it doesn't make any difference in how the prognosis or the treatment, because that's what the syndromes are all about. It also didn't matter how old they were. Younger kids weren't more likely to have them than older, but it did matter the duration. So the longer the seizure was, the more likely the kid was going to have automatisms, which kind of makes sense, more opportunity. It didn't matter whether the seizure was in awake, drowsiness, or sleep, but it did matter in terms of the provocation. So the seizures that were induced in the EEGs by hyperventilation, there was much more, you're more likely to get an automatism. So what this study and other studies showed was that this particular feature, automatisms, is really more, it's about the environment or how, what's going on around the kid and what they're doing when they have the seizure, not about anything individual to the child or individual to the particular syndrome that they have. And so that is why these the way they looked at them when they were just trying to divvy up absence seizures based on what they looked like, now we know actually there's only some features that are important from prognostic and treatment. And that's why the classification has subsequently changed. So getting back now, finally, almost finished, to the collaboration between SNOMED and the ILAE, where, just to remind you, our goal is to enhance the content related to seizures and epilepsy so that clinicians can have the latest evidence-based content for point of care to help with data collection, with also in terms of resourcing and research. And what we're doing, so the plan is, so we're now working together, and what we're doing is the plan is to add the new 2017 seizure type and epilepsy syndrome terminology as the first step. We also want to inactivate the seizure and epilepsy terminology, which is outdated and not helpful, such as absences with automatisms. And we also need to organize the seizure and the epilepsy terminology relationships that are in SNOMED in a conceptual way that makes sense with our present understanding of seizures and epilepsy. At the moment, some seizures are listed as disorders and some syndromes are listed as finding. It's really not consistent, and it doesn't make a lot of sense. So we need to sort of put some rationale and consistency within the SNOMED terms. And to put it into perspective, there's something like 500 epilepsy and seizure terms in SNOMED. So this is going to be a big task. So just in summary, hopefully my take-home messages are that, you remember that epilepsy is a group of disorders which ultimately we want to be able to diagnose as syndrome that are defined predominantly, but not only, by the specific seizure type. So it's important to have good classification and terminology when we're describing seizures. That the ILAE is an organization with its goal to improve epilepsy care, and that they've recently put out new position statements on concepts and terminology, which we want to get into SNOMED, that these changes reflect advances in our understanding and as well as our desire to make these words understandable and usable for everybody at all level in all countries. And that ultimately what we're doing is this collaboration will add new terminology. It will inactivate what we feel is unhelpful terminology, and will realign terminology in SNOMED to be more useful from a clinical resource allocation and research perspective. And so this is what is going to be happening over the next few years. And so we thought it was important to come to this clinical webinar to let you know what's on the horizon. So that is it for me, and I'm happy to take questions. Hopefully there's somebody still there. It's weird talking to yourself for a long time. Oh, yes, you are still there. I didn't just get cut off. Still here.
So thank you, Lynette. So I'd like to remind any of the attendees, if you have questions, put them in the Q&A box on the bottom of your screen, and we'll ask Lynette the questions as we go along.
Shall I stop sharing, Ian, or do you want me to?
No, you can leave the screen up. That's
okay.
Fine. So firstly, thank you for the presentation. I'm now far more informed about epilepsy than I ever was previously, which is good.
That is good, Ian.
I think there's a couple of things which strike me about your presentation. One certainly is the overlap of the ILAE countries with the SNOMED countries. So with the exception of Iceland and Brunei, which we can work on together if you want to create chapters in those two countries. But for the others, it's one of the areas which is obviously has clinical importance to our members, essentially. So we have 41 member countries, 39 of them overlap with you. So one, it's an important thing to focus on in terms of epilepsy. Certainly it's helpful to look at it in terms the way you did in terms of what we're referring to in SNOMED. So we tend to focus a lot on disorders for obvious reasons, but I think your presentation proves the value in some ways, or emphasize the value of the clinical findings to make that diagnosis, and making sure that the up-to-date content is available in SNOMED is essential, because otherwise you effectively can't do your job in some ways. The one challenge which we always get thrown back at us in some ways, particularly when we make large-scale changes in SNOMED. SNOMED is obviously used in all healthcare sectors. So whether you're talking about generalists, specialists like yourselves, primary care, where do you think the changes in the classification of epilepsy will feed down to some of those other groups? So obviously within people whose job, if you like, is epilepsy, then the ILAE classification is obviously very important. But how do you feed that out to the more generalized clinicians?
Well, I mean, when we're devising these terminology, we're looking at medical students and we're looking at people with epilepsy. These are terms being used by patients for their seizure types that they find useful. So anybody in health that has anything to do with somebody with epilepsy will find these terms useful. And I guess you could argue, so I guess if somebody never sees anybody with epilepsy and never has anything to do with anybody with epilepsy, well, why would they use SNOMED terminology of epilepsy anyway? But at any stage, so, a patient comes into the emergency department, they're seen by an emergency physician, or they go to their GP, or they go to their physiotherapist, or they go to, they're seen by a medical student. These terms are, the idea is that the terms and the concepts are useful for them at every single level. Now, the classification system is such that it becomes more and more granular. So the more, higher up you are in terms of, well, not higher up, but, the more specialized you are, the more granular you might want to be in your classification. So for instance, if you're a patient or somebody in ED, you might really need to just get to the fact that they have had focal seizures or focal impaired awareness seizures. Whereas your pediatric neurologist might be saying, well, this is a focal impaired awareness motor seizure. And your surgical surgeon who's going to do epilepsy surgery might be saying, well, this is a focal impaired awareness myoclonic surgery, so that it can become more and more granular. So the less specialized you are, the less granular you need to be in the classification. But in terms of the terms, they all fit in. So it's really important, I think, at every level. The terms previously that were used in the 1989 classification of complex partial seizures, I don't know how, the whole first 10 years of my life trying to teach medical students what a complex partial seizure was. Like, it's just completely, I don't know what people were thinking when they made those terms. It doesn't make any sense, you know? Whereas now I teach medical students, I say it's a focal, you explain what focal onset is, and it's an impaired awareness seizure. It's easy. They get it. The patients get it. The GPs get it. It's just a much better classification.
I think the one thing that struck me was actually one of your earlier slides, or one of the earlier slides in the presentation. One is effectively your outcome is based very much on the type of epilepsy you have, and therefore the treatment that you receive as part of that. And one of the things, which is a general statement, it's not necessarily about SNOMED in general, but the public in general is becoming more informed now. So, it's not uncommon for patients to turn up in general practice with, knowing almost more about their own syndrome or what they think they have than the clinician that's treating them, which is an interesting move in some ways. But certainly having, if you have got epilepsy, it's not uncommon for you to go to the ILAE website and do your research on the internet to find out exactly what it is. So, having coverage, the latest coverage in some ways in SNOMED, will always be helpful in terms of not just the clinician accessing the patient record, but potentially the patient accessing the patient's record.
It's really important, isn't it, that everybody is on the same page and using the same terminology and understands the same thing. Otherwise, and I think as I was saying about the medical student, I think one thing that reflects well on whether you've got it right or you've got it, is how easy is it to teach to people who know nothing about it. So, and it is absolutely the new terminology, the new classification is easy to teach. So it's hard to teach the old dogs new tricks, the ones that are kind of embedded in the way it was. But when you're trying to explain epilepsy and get people to understand the disorders, the new classification works well. These terms and concepts work well.
They do. So I'm going to stop rabbiting a bit. We've had a comment and a question from the audience. So this is from Anthony. Thank you for the talk. Very interesting. The SNOMED is in urgent need for its section on epilepsy terms to be updated and reorganized. So I
agree.
I think you and I would both agree with that statement.
Yes.
So is there a time frame for this? And what's the best approach to doing stuff like this faster in the future? I can answer the second part. Do you want to answer the first part?
Ideally, we would like to do it as quickly as possible. So maybe I should start with, when did we start? When did we approach you, Ian, with this? Maybe it's been a year and a half or 2 years so far?
Year and a half. So it was mid-2019.
And we are hoping that in January, there might be 20 terms that are released. So but it's gonna roll up. So the ILAE's the classification, the task forces in the ILAE are sort of 3 to 4 year terms. And I am the chair of the SNOMED classification task force. And so I'm hoping that we'll have all this done in my term, but it will take a while, I think. But we'll start off with the important stuff, which will be getting the new terminology in and trying to inactivate stuff that's not useful, and then reorganize things and then kind of refine it. So I don't know, what's your comments on that, Ian?
So the one comment I'd make on this is actually a general comment, and they'll come down to epilepsy. So in terms of this approach, so Lynette made it obvious that they approached us rather than the other way around. So one of the challenges SNOMED has always been the fact that it's the biggest global terminology, which is good in the sense that it has broad coverage. It's bad from the point of view it has broad coverage. So one of our challenges is always keeping up to date with clinical practice from all the different clinical specialties. So having having a group, and the other thing to say actually is the focus of SNOMED is obviously international, not at the national level. So having a group like the ILAE approach us to actually focus on content is our preferred option, if you like, in terms of how to approach organization or reorganizing and updating content in SNOMED. The challenge in actually doing the work, and I'm sure Lynette will agree with this and has the scars to prove it, is actually twofold. One is to actually wade through SNOMED to work out what is missing. So in terms of a classification like the ILAE, it obviously, the structure of it is very different to what's in SNOMED currently. So one is actually making sense of what's in SNOMED, bearing in mind the organization will be completely different between the two terminologies. To then actually go through that and then work out what's missing and also what is outdated. And if you retire it or deprecate it, as we refer to it, is it, what do you replace it with? Or is it replaced by a new term? So is it just called something else now? Or is it something which has completely changed, which is just no longer of clinical use? Bearing in mind that we don't just take things out of SNOMED, but we take them out and provide history so that you can go back to earlier records that have been recorded using earlier versions of SNOMED and work out what was meant by the clinician when they recorded it. So some challenges in terms of just the work. So the work isn't easy. The best approach is obviously to have an ongoing relationship between SNOMED and ILAE, which is what we intend to do. So Lynette and her, the team at ILAE have almost had the worst case scenario because nothing in SNOMED has been done with epilepsy in my lifetime. Well, in my lifetime with SNOMED. And I've worked with SNOMED for a long time. So one, if you don't update it for literally decades, it's not surprising that it becomes out of date. So having that ongoing relationship and a mechanism to make updates makes the work faster in the future, to answer the last part of it, the question. The challenge is to get it to that stage requires a lot of upheaval and a lot of work. And that's why Lynette and the team have the scars to prove it, as does the SNOMED authoring team that's supporting you, to be fair.
I know, it's like we're coming from two different, we're taught, it's kind of ironic that this is all about terminology, and yet we are actually talking very different languages to start with. So it's all about coming together and understanding each other so we can move forward.
So I have one question for you, which is interesting. So we'll finish on this one. So thank you for a nice lecture. Will there be other lectures about other types of epilepsy?
Oh, this was going to be a little bit more like about different types of epilepsy until I realized that I needed to make it more about terminology and classification. I'm sure I can give more talks on epilepsy if people are interested in them. The other place, of course, is to go to the ILAE, International League Against Epilepsy website, and there are some excellent online webinars on there about various different types of epilepsy. And a really good place to go is the ILAE has a website called epilepsydiagnosis.org, and it is sort of the flagship educational resource for all of the different epilepsy seizure types and epilepsy types. And when you go on there, there's also videos of all the different seizures. So we set that up. I think it went live about 4 or 5 years ago, and it is constantly being updated. So when the nosology, when the new syndromology papers come out, that will also get updated with those. So those are places you can go. But I'd be happy to come back and give a lecture if anybody wants to hear it. The more I can talk about epilepsy, the better.
Okay, well, we're at the top of the hour. So I'd like to bring this webinar to a close, but I'd like to thank you, Lynette, for a very interesting and stimulating talk. I certainly feel more educated about epilepsy than I did when I started. So you've obviously increased my knowledge, if nothing else. So I'd like to thank you all for attending, and thank you, Lynette, for presenting. And I'll bring this session to a close. So thank you.
Thank you.